Hi, the fourth interesting topic is on gastrointestinal injury caused by aspirin or clopidogrel monotherapy versus dual antiplatelet therapy. As we know, patients who undergo percutaneous coronary intervention with drug-eluting stent require dual antiplatelet therapy for at least 6 months for stable ischemic heart disease or 12 months for acute coronary syndrome to prevent stent thrombosis and other cardiovascular events. The rationale for using dual antiplatelet therapy is that aspirin and P2Y12 antagonists like clopidogrel or prasugrel separately inhibit the COX-1 and the adenosine diphosphate dependent pathways, and together confer greater protection against the platelet activation and stent thrombosis than either antagonist alone. Mounting evidence suggests that a short course of dual antiplatelet therapy by single antiplatelet therapy reduces bleeding without increasing ischemic events in patients with either stable ischemic heart disease or acute coronary syndrome. But it is uncertain whether using either aspirin or P2Y12 antagonist alone reduces GI injury. To compare the separate and combined GI effect of aspirin and clopidogrel, Han et al. Performed a serial capsule endoscopy after treatment with three different antiplatelet regimens, which are as follows: single antiplatelet therapy using low dose aspirin alone, in which 168 were enrolled, or clopidogrel alone, in which 169 were enrolled, or dual antiplatelet therapy using low dose aspirin plus clopidogrel, in which 168 were enrolled. In the study, almost every patient had erosions in the stomach or small intestine on every capsule endoscopy study, and 83% of the patients had some evidence of GI injury at baseline, despite the fact that 39% of the patients were not on antiplatelet therapy before admission, but were presumably on dual antiplatelet therapy for the 30 to 120 hours from PCI to the time of capsule endoscopy. When the analysis focused on the subgroup of 68 patients without erosions, ulcers, or bleeding on pre-randomization capsule endoscopy, the investigators found that single antiplatelet therapy caused less GI mucosal injury, including fewer new ulcers, than did with dual antiplatelet therapy. The investigators found that the secondary endpoint of any type of GI bleeding between 6 and 12 months was less than single antiplatelet therapy compared with dual antiplatelet therapy, without an increase in ischemic events. Moreover, the overt GI bleeding was 90% lower with single antiplatelet therapy than with dual antiplatelet therapy. The other secondary outcome of clinical overt bleeding at any site, which was primarily Bleeding Academic Research Consortium 1, was also lower with single antiplatelet therapy than with dual antiplatelet therapy, which was similar to the treatment effect reported in most contemporary trials evaluating single antiplatelet and short course of dual antiplatelet therapy. This study finally concluded that first, using aspirin or clopidogrel monotherapy after 6 months course of dual antiplatelet therapy in patients undergoing PCI predominantly for ACS had a better safety record than using a 12-month course dual antiplatelet therapy. In the present study, the investigator found no difference in the bleeding or ulceration in either the stomach or small intestine, a finding that challenges the conventional wisdom that aspirin is the culprit in dual antiplatelet therapy responsible for GI injury and raises the possibility that clopidogrel, which does not inhibit COX-1 but target P2Y12 receptors, may be ulcerogenic or impair the healing of mucosal injury due to other causes. The third conclusion point was that the history of GI bleeding in patients undergoing PCI is the strongest risk factor for bleeding after hospital discharge. The fourth point was that the patient at high bleeding risk undergoing PCI should thus be considered for a single antiplatelet therapy after 1 to 3 months of dual antiplatelet therapy after PCI, as long as they remain at low risk of ischemic events, and they should also receive proton pump inhibitors. The fifth point was that the erosion as a marker for GI injury are not really useful as a clinical endpoint or a discriminator of safety. Therefore, doctors should be more concerned with symptomatic ulceration or overt bleeding than with incidental endoscopic erosions. The study suggests that antiplatelet effect of single antiplatelet therapy or dual antiplatelet therapy is likely of greater importance as a cause of GI bleeding than the mucosal effect of low dose aspirin. Thank you.